Okay,
Oh,
so hi, all of you. You know us. My name is Ross Sonnenblick. I am a third year PhD student in clinical psychology at Drexel University, where my research and clinical work focus on disordered eating in boys and men. And Callie, who is Callie?
yes, everyone pretty much knows me here, but I am now a fourth year in the University of South Alabama's Clinical and Counseling Psychology program. I moved up to Connecticut at the beginning of this year to start a pre-doctoral fellowship. So I work full-time at Yale School of Medicine, running clinical treatment studies for teens with eating disorders. My clinical work has focused a lot on how gender roles impact health behaviors, particularly disordered eating and body image related variables, which has resulted in me being quite interested in men and boys' experiences of eating disorders. So we're quite excited to be able to chat with you about this today. If feel free to interrupt, hand raise, whatever you feel best about. If there are times where you want us to slow down or speed up, let us know. But without further ado, shall we go ahead and get started, Ross?
I think we shall.
Amazing. Okay.
Cool.
So
So, what were you going to say, Callie?
go for it, Ross.
Okay, yes. So here we see our fancy agenda here. We're going to start with a bit of an interactive activity just to get our creative juices flowing in thinking about what comes to mind when we say disordered eating. Then we're going to present some facts and fictions about eating disorders. We are going to dive into the research and what has come up lately where researchers are focusing their attention in this area. We will talk about signs and symptoms of disordered eating in boys and men. We will talk about the current best practices, gold standard assessment methods, and treatment procedures for disordered eating in men. We will then return to research and talk about research that ideally would happen in the space over the next couple of years. And then at the end, if we haven't fielded questions along the way, we are happy to do so at that point.
And all within 45 minutes. So we've got this. We were initially going to do a word cloud, and we totally can. If you want to get really fancy and use your phone to scan this QR code, or we can just kind of do a popcorn method, unmute yourself. But what we wanted to start with was just asking people, what are some stereotypes that you typically hear about people with eating disorders or with disordered eating? Who do you think of typically when we're thinking of people with eating disorders?
Who do you think of, or what do you think of about
Who do you think of? What do you think of? Anything's fair game here.
Wi-
compulsion?
Women.
Okay. Women, right off the bat, Holly, and I'm hearing compulsion from you, Daniel. Do you want to say a little more about that?
Compulsion?
Yeah.
I'm not. I have no compulsion to do so. No, I just the a very addictive quality. You know that and addictive is kind of to be enslaved by something. So it's something that has control over people versus the other way around.
Okay, and I like that phrasing that you used there, kind of out of control, like being controlled by something. Yeah, okay. What else comes to mind for people?
They're superficial. It's all about their looks,
Mm,
and especially the superficial part, right? Like nobody else cares about looks. Like that's not a cultural thing.
right, right.
I think about overweight.
Okay. Can you say more about that, Dan?
Yeah, just on the binging side of
Okay,
things.
gotcha. Gotcha.
Which is an acknowledgement that there are sides. There's maybe a binging side. And then if that's one side, uh, Danny, what are you thinking is the other side?
Well, is it like, you can binge and purge, or you can just binge, or you can restrict,
Hmm.
or others. Like, but I'm just thinking like my kind of go-to associations. It's those.
Right, absolutely. And I'm seeing some things pop up here like insecure, anxious, depressed. Okay, fantastic. So I want to really point out as well, I know as we're clinicians, we can also come at it from this angle as well, but when Holly said women, I think that was a really fantastic example of what the general population typically considers as who struggles with eating disorders. We typically are thinking young white women, wealthy women in particular. And we're also associating, even in some of these other features that we mentioned, there is a little bit of a gendered connotation and association with those as well, right? When we're thinking feeling out of control or compulsed to do something, but not having control over something, or that lack of control. If we're thinking maybe more anxious, if we're thinking maybe superficial, these are words more typically at times that have been described to talk about women's experience rather than men's experience. So when we're thinking about just cultural stereotypes about eating disorders, a lot of the time they're associated with more things or traits that our culture is considered to be more feminine. So we want to jump back. Ross is going to take us through some fantastic fact or fiction pieces here. So the first fact, go ahead, Ross.
Yes, to which Holly sort of just spoke. It's this idea that only women develop eating disorders, particularly given the fact that the name of our presentation is Disordered Eating in Boys and Men. You might be inclined now to think that actually this is a fiction, not a fact. And that is definitely true. So what we know, according to our best epidemiological estimates, is that men account for about 1/4 of adults with anorexia and bulimia, and about 1/3 of adults with binge eating disorder. And just to make sure that we are all entirely on the same page, I realize I don't know how much familiarity people have with the different diagnoses, so I thought I would just say a couple of things about these conventional eating disorders. So anorexia nervosa is this restrictive kind of eating disorder, to use Danny's term. So anorexia is characterized by the failure to maintain a sufficient body weight or notable weight loss over a period of time, along with an intense fear of gaining weight and disturbance in body perception. So not seeing themselves how they actually appear, maybe thinking they're extremely fat, even when, according to any objective observer, they would be really thin. Bulimia nervosa is this combination of binging and purging, in which one's self-evaluation, how one sees oneself, is overly tied to one's shape and weight. And then binge eating disorder contains only that element of binge eating without the purging. And then the person also needs to be unduly distressed by the binge eating, which is just in keeping with any DSM diagnosis needing the clinically significant distress or impairment. So again, men account for at least 1/4 of adults with these conventional thinness-oriented eating disorders. Now we can go to the next one, Callie. Yeah, so if we think within the men who do develop eating disorders, do we think that eating disorders mostly affect young men? If people want to chime in, they can, or otherwise I can answer for myself. Eating disorders affect men at any age. And so while it is true that eating disorders mostly affect young women within the ranks of women, it seems increasingly like there is evidence that the rates of eating disorders in men, even if they don't increase with age, they at least do not decrease with age. So we could just as easily see a middle-aged or older man with an eating disorder as a younger man with an eating disorder, which just means that it's really important that we not let our guard down when, as we'll talk about later, screening or assessing for eating disorders among any age group of men. Okay. Eating disorders, as it turns out, do not mostly affect white men. So this is another one of these fictions. There's pretty good evidence that binge eating in particular seems to be most prevalent among Latino or Hispanic men. There are higher rates of these muscle building behaviors that can be associated with disordered eating in Asian American men. And we also know that Black men and boys engage in more unhealthy weight control behaviors than white men. So this is really a problem across race and ethnicity. There's also this idea that eating disorders might predominantly affect more economically advantaged men, but in fact, there's fairly good reason to believe that this is not the case. Looking across eating disorders in all genders, we know that individuals with food insecurity show higher eating pathology and especially higher rates of binge eating. But I should say that this work has not disaggregated men and women yet, and we can return to that when we talk about research gaps. Okay, here we have the notion that eating disorders might mostly affect gay men. And here I would want to add some nuance. So we do know, and this is pretty well documented, that sexual minority men have a higher risk of eating disorders than heterosexual men. That is pretty well established. But if we think about just absolute rates of eating disorders, there are more heterosexual men with eating disorders than sexual minority men with eating disorders, just because there are more heterosexual men. There's also some evidence that sexual minority men might be more likely to develop these thinness-oriented eating disorders. So we're thinking about the more conventional ones, the anorexia, bulimia, and binge eating disorder, whereas it might be true on average that heterosexual men are more likely to develop muscularity-oriented disordered eating, where it's much more about this pursuit of increased muscle mass than it is about the decrease in one's fat. But as always, there are exceptions to every rule, and so this is a gross kind of generalization that I'm making here. Okay. Well, I just talked a little bit about muscularity-oriented disordered eating, which is a main distinction, again, with some exceptions, between the disordered eating of men and women. We know in general that men are as likely to develop muscularity-oriented disordered eating as women are to develop thinness-oriented disordered eating, which again just means that men are more likely to have this pathological desire to gain muscle, whereas women on average are more likely to be focused on losing weight to an unhealthy degree. And Callie might discuss this a little bit later regarding the muscular ideal in more depth. Okay. Eating disorders are only serious among adults who are underweight. Well, it might not surprise anyone to hear that this is another one of these fictions. So it is true that anorexia nervosa has one of the highest case fatality rates of any mental illness, and anorexia is largely associated with underweight status. But the other conditions, including binge eating disorder, are associated with serious medical consequences in their own right. So we're thinking obesity, diabetes, high cholesterol, heart disease, etc., along with lowered quality of life and other psychiatric comorbidities. Okay, here I thought I would catch everyone off guard a little bit with a fact. So this is actually true. Until 2013, with the release of the DSM-5, men technically could not meet DSM criteria for anorexia nervosa.
Does anyone, before you spill the beans, Ross, does anyone know why?
Because it was based on
Stop menstruating.
statistics of like a body mass index or something.
So not quite.
I think I heard,
They
did
couldn't-
someone else chime in?
Yeah, I think
Yeah,
Andrew.
that's me, Andrew. They couldn't stop menstruating.
Yes, such a good point. Yes. So there's this requirement about amenorrhea, and men could not lose their menstrual cycles, not having had menstrual cycles to begin with, if we're talking about cisgender men here.
men in
Yes,
particular.
exactly. Yes. Okay. And then finally, eating disorder treatment doesn't work for men. Fortunately, this is largely a fiction. So we can talk more about treatments later. We will talk about treatments later, but there are several studies that show that men can reach remission from anorexia, bulimia, and binge eating disorder at least as quickly and as often as women do.
Awesome. Fantastic, Ross. So I'm going to dive us a little bit deeper into some of the more recent research findings that are kind of supporting some of what Ross was saying on the previous slide. So it used to be the case that everyone who wrote an article about men's disordered eating started that article by saying that there is not enough and almost no research on men's experiences of eating disorders. And slowly but surely that is becoming not true anymore, which is fantastic and great. In the last 5 to 10 years, and there's a beautiful little graph here that shows just how much research on and publications focusing on men and boys' experiences of disordered eating and body image related variables have really exploded within this time period, which is great. So I'm going to give you the SparkNotes version of what some of this research is saying, and then we'll talk a little bit later about some gaps and what we're missing. I wanted to really hammer home, though, that when we're thinking about boys and men, their experiences of eating disorders, particularly prevalence rates, they can be very, very misleading, even in our current reflections of research. And one of the great findings that points to why this maybe is because boys with clinically significant eating disorders that cannot be classified using DSM-5 criteria vastly outnumber those that can or meet criteria in our current DSM definitions of eating disorders, even people who are sub-threshold, so don't quite meet those criteria, about 3 to 1. So for every one boy who meets that DSM criteria, there's three more boys out there who their experience of what looks like an eating disorder does not perfectly line up with what's reflected in the DSM and how we diagnose, which is really important because at its core, the way that eating disorders have been defined is probably contributing to their heightened prevalence rates in girls and women. So this is really important. Something that I really hope that you all take away is that more work, just everything that we're talking about in terms of research needs to be contextualized, that it's done predominantly from the standpoint of women and girls' experiences. And we're slowly moving away from that. That being said, it's going to take some time, and we'll talk about that in screening and future research. Some of the demographic groups that we've already talked about as associated with increased risk for the development of an eating disorder. So Ross mentioned sexual and gender minority men being at a higher likelihood of developing eating disorders than straight and cisgender men. There's been research recently that shows that in part this is due to minority stressors, right? The minority stress model has shown that it leads to the development of some disordered eating issues in men, and heightened body ideal internalization and endorsement within some of those communities. Trans men in particular are at risk. Initially, the research was kind of showing that trans men had a greater desire to gain more muscle or more fat, to appear larger. However, this is now kind of split 50-50, where just like in cis men, trans men, about half of them report wanting to gain weight, half of them report wanting to lose weight. And the ones who want to lose weight or lose fat are typically to suppress some of those expression of female secondary sex characteristics. Athletes are also, male athletes are also at an increased risk, particularly those in weight sensitive and aesthetic sports, right? So when we're thinking weight sensitive, anything with a weight class. When we're thinking aesthetic, we're thinking figure skating, gymnastics, bodybuilding. All of these sports for men have been shown to be linked to increased risk for the development of an eating disorder. Eating disorders in athletes more recently, some of the recent research has tied this to sports-related injuries, dysregulation of metabolic rate, organ systems, testosterone and bone health. And so I think it's fantastic to see some of the newer research kind of exploding in that area, looking at how specifically the development of eating disorders in male athletes impacts these more biologically health-related variables, which is so important. We talked a little bit about racial and ethnic minorities. We actually find that Black boys and men, Hispanic men, Asian American men, and even Native American men, the research in this population is way lower, tend to engage in both more unhealthy weight control behaviors and muscle enhancing behaviors than white boys and men, right? So the idea that white boys or white women are, or white boys and men, white women and girls are more likely to develop eating disorders, quite frankly, over the last couple of decades has just been proven false. And there's also research that the trajectory of development is different based on racial and ethnic group. So particularly for Hispanic men, or in Hispanic boys, the trajectory for binge eating disorder seems to start a little bit earlier versus and kind of reach a little bit of a peak in late adolescence, early adulthood, versus for other groups, it tends to be a pretty stable increase in likelihood of development across time. Also, men in midlife. I know that Ross mentioned age as not a variable that's super related to disordered eating in men, that men across lifespan can develop eating disorders, but it's actually quite interesting. More recent research is suggesting that just like adolescence and weight changes in adolescence for girls is contributed to the higher risk of onset for an eating disorder, so are biological and weight changes that happen for men in midlife. So we're thinking about weight gain, we're thinking about reductions in testosterone, medical issues, and changing life roles. So whether that be a divorce, a separation, or retiring from work, all of these have been linked to the development of disordered eating for men in midlife.
And Callie, could I jump in on that point?
Of course.
Awesome. Thank you. Yeah. So just one sort of eye-popping fact that I saw at some point was that 50% of eating disorder cases in men at age 50 are new onset cases, which I think speaks exactly to this midlife crisis of sorts that men might be experiencing.
Absolutely. No, it's fascinating, and definitely not the group of men that we think are most at risk for developing an eating disorder. So as clinicians, this is such an important fact to get out there. And then finally, like Ross mentioned before, whether or not people who experience income and food insecurity is linked to higher rates of eating disorders in men is kind of unknown. We haven't looked at gender as a moderator in this relationship. We haven't looked at it intersectionally with looking at gender and race. And I think all of that is important research for the future. But in general, people who experience income and food insecurity have been shown to have higher rates of eating disorder risk. And then finally, this little image down here, I won't talk too long on it, but this is called the tripartite model for the development of eating disorders. And particularly this model has been adapted for men. So what we think about sociocultural pressures are as a huge risk factor for the development of eating disorders for both men and women, and boys and girls. But for boys in particular, social media use, editing photos to post on social media, and pornography use are all associated with increased risk of developing an eating disorder. People often talk about girls' relationships with their moms as contributing to the development of eating disorders in girls and young women. However, it's also the case that maternal and paternal pressures for young boys or young men to lose weight is also associated with the development of disordered eating in boys and men. And partner pressure as well, particularly partner pressure to be more muscular, has been related to the development of disordered eating in men and boys, which leads to all of these sociocultural pressures lead to greater internalization of when we think about men, we think of almost two separate ideals. So the lean ideal, which touts that the best looking bodies are lean, they're toned, think Cristiano Ronaldo, famous soccer players, right? And the muscular ideal, which kind of touts that the best looking bodies are super buff. Chris Pratt, when he was in all of the superhero movies, is the first example who came to my mind, but there you go, which can almost lead to two different directions of development for disordered eating behaviors, one through muscularity concerns, one through body fat concerns, and either can develop into muscularity enhancing behaviors or disordered eating behaviors. Okay, so Ross, do you want to cover some of the physical symptoms?
Yes, by all means. So I won't linger on these for too long, but these are some symptoms that we might expect to see or could clue us into the existence of disordered eating in men and boys. We might see sudden weight loss, weight gain, or even considerable fluctuation in weight. Then let's see, the next one is specific to children and teenagers. this is more when we think about anorexia nervosa in particular, we might see this departure from the previous growth curve on which they would have been gaining weight steadily over time. But in this case, we would see a failure to grow as expected. The next one is a pronounced change in appearance. And so it was funny that Callie mentioned other Marvel superhero movies, because here I have Captain America. As far as we know, he didn't have disordered eating, but he did in fact undergo this sharp increase in muscle mass through something like an anabolic steroid, although I guess it's also some sort of magical drug that doesn't exist in real life. We could also be looking for signs of vomiting, although what I would want to suggest here is that this sort of compensatory behavior, this purging behavior of vomiting, is much less common in men than it is in women. In men, we would be much more likely to see some of the symptoms that are listed on subsequent slides, like excessive exercise, to get rid of these additional calories that are consumed during a binge episode. We could also be looking for bloating, constipation, or new food intolerances, and I'll speak a little bit more about those on the next slide. We could also be looking for exhaustion. So this is particularly true of people who are restricting what they're eating and just not consuming enough energy throughout the course of the day. We could also see extreme sensitivity to cold, which is basically about this failure to maintain a minimum level of necessary body fat. So there's just not insulation for the body. And here I would say that I can speak from personal experience. I think most of the people who are here actually initially met me at the APA annual convention in 2023, where I think my introduction to most of you was self-disclosing a history of anorexia nervosa, which is very true. I did have anorexia when I was in later high school. And I know that for myself, I spent most of that time freezing, just absolutely freezing. The only times I could get warm were when I was exercising and exercising excessively, or when I was curled up under multiple blankets on a couch, because otherwise I just could not keep myself warm, which I don't say to elicit too much pity right now, but just to say that the extreme sensitivity to colds really is a salient symptom of disordered eating for people who have lost weight. And then the last one here is about decreased testosterone or libido. Okay, I think we can move on, Callie. Yeah. So here we're looking at now these psychological symptoms, one of which is over concern with body shape, appearance, or weight. So that essentially means that someone is considering body shape and appearance too prominently in the list of factors that influence how they think about themselves. So they're too hung up on body shape or that sort of thing. They might also be very preoccupied with food, eating, or calories. They might be diverting attention from more important things to food, eating, and calories, which goes along with this black and white thinking about the goodness or badness of food. So there's kind of this rigid categorization of food as either good or bad and best to be avoided. We are, unsurprisingly, also looking for body dissatisfaction, or particularly in men, the drive for muscularity. Although, as Callie mentioned, there are these two different pathways, one of which leads to more muscularity-oriented behaviors, and one of which is more about these weight-reducing or body size-reducing behaviors. There's this concept of gastrointestinal visceral sensitivity, which is admittedly a mouthful. But on the previous slide, when I mentioned bloating and constipation, I said I would get back to them, and I will do so here, because there's this idea essentially that people with disordered eating tends to overinterpret symptoms from their gut, essentially. So if they're feeling very full, that might concern them. If they're feeling constipated, they might make a bigger deal out of that than other people might.
Right.
That's sort of this visceral sensitivity.
And definitely, just to add here, there's almost like a cyclical nature of this, or a two-way relationship. So A, they're more sensitive to it, but also B, their disordered eating habits can also result in symptoms like delayed gastric emptying, which means that their bodies are holding onto food for longer, or some of the very real stomach issues that can happen with in the aftermath of, say, binge eating behaviors or purging behaviors. So it's a bit of a two-way street here. Like, yes, it can be psychologically influenced, but also there's probably a little bit of physical truth here. Chicken or the egg situation.
Thanks, Kylie.
Yeah.
Okay, and then we can actually, I think, put the next couple on simultaneously here. So yes, here we're seeing essentially that disordered eating is associated with a host of psychiatric comorbidities. So it shouldn't surprise us that disordered eating, particularly possibly in men, would lead to low self-esteem and increased shame, because there is this perception that this is a predominantly female problem. So if you are a man with an eating disorder, this problem is compounded. It's like, what are you doing wrong to make you develop this problem that is associated with people of the opposite gender? And then in terms of, anxiety and depression, again, those come hand in hand with just general psychological distress. Okay. Now, if we think about some of these behavioral symptoms, I already mentioned that we might see excessive exercising as a primary compensatory behavior in bulimia nervosa, but also just generally across men with disordered eating. They are often going to exercise as a way to improve their physique when they don't think that they can possibly improve it enough. Okay, then you might see this prioritization of exercise over social events. Previously social people might seem to withdraw into themselves when really it's because they can't make themselves stop exercising.
Right. And this is honestly something that I see come up all the time with young men with eating disorders in particular, which has been the population that I've mostly worked with. One of them was brought into treatment because his girlfriend was so upset that he was going to the gym for hours every day rather than spending time with her. And over the course of treatment, we were able to get to a point where he was able to take a day off from the gym. But when he initially came into treatment, he was like, I don't know, it's impacting my relationship. I guess I maybe have a problem. So this might be a huge piece that might cause other people to maybe say, why don't you go and speak to someone?
And yeah, Callie, while we're at it, in the interest of time, I think you can skip all the way through to 10. And
Awesome.
that'll also shed some light on why there's a random sweatshirt in the bottom right corner, which is because a symptom that we might tend to overlook is just this preference for baggy clothing and also an avoidance of activities that showcase the body. So this is even true of people like the young man whom Callie treated, who was spending so much time at the gym. Even as he was spending so much time at the gym and probably making himself legitimately very strong, he was also probably intensely embarrassed about his physical appearance and probably hid it. Yes, Danny.
I wanted to ask, where where do medications like Ozempic and Wegovy and like I'm seeing much more of that certainly in our practice and out in the popular culture. And I just wanted to know if y'all are going to touch on that. If so, like how do you see that fitting in? What's if there's research on it?
I can take this one, Ross, if you like.
Mhm.
Just about every presentation discussion with parents over the last couple months I've had, this question has come up. In terms of, well, weight loss drugs, Ozempic, where do you see it? I think it's honestly right now in terms of the research, early days. There hasn't been a lot published on it. With the exception of, like any other weight loss drug, weight loss over-the-counter medications have been abused by patients with eating disorders for a very long time. Ozempic is no exception. So when it is used in a way that it's not medically intended to, it can cause negative outcomes, the same as just many of the other pre-existing over-the-counter weight loss medications. That being said, it is helpful for some people who use it for weight management strategies. So I don't love the idea of throwing the baby out with the bathwater, which I think a lot of people have kind of jumped to within the pop culture because we hear the horror stories and hear the stories of people taking it who as not as prescribed or not as directed, which is awful. And I don't want us to lose sight of the fact that yes, this was happening before. It's just now it's in pop culture light. Does that kind of answer your question, Dan? I don't know if you have anything to add.
Yeah,
Ross.
it does. It does 100%. And
Okay.
and what you're saying about Latino men and sort of the lifetime distribution of it, it got me thinking sort of in biological terms. Obviously not me, but other people that I know who are in middle age are experiencing a change in metabolism. And I was just thinking about some of those kind of lifespan aspects of how it might relate to the later onset. Again, obviously not me because I'm fit and perfect looking.
Must be nice. Yeah.
Yeah.
And then the cheeky answer to add on is just that my research team here at Drexel does a lot of clinical trials of treatments for eating disorders, and use of any of these weight loss medications is an exclusion criterion so that we can get around that particular confounding variable. Okay, I think we can move on, Callie. Okay, so yes, before we talk about our best practices for assessment and treatment, I thought I would just quickly say here that if we press the next bullet, yes, men with eating disorders are half as likely as women with eating disorders to seek treatment. And that's according to the literature. I would even imagine that that number is much lower because we're so bad at identifying men with eating disorders. So that said, why are some reasons why men might be less likely to seek treatment? Well, as we mentioned, there's this misperception of eating disorders as a female problem by everyone, not just the men themselves, but also by even up to and including medical professionals. We've mentioned this internalized stigma and shame that comes from developing a condition associated with women, or at least not with oneself, according to one's own self-perception, which leads to this fear of judgment and also fits in with social norms about help seeking in people who identify as men. And then there's also this tendency of men to downplay the severity of their symptoms. So particularly, I think this is true for disordered eating that doesn't look like losing a ton of weight to the extent that it's clearly unhealthy. Men who are just like maybe a bit overweight, and maybe have binge eating might not actually be that concerned, at least in the short term, about how much damage they are doing to their bodies. I focused my master's thesis on examining this question of why men with binge spectrum eating disorders in particular don't seek treatment for eating disorders. And I heard from at least 2 men that they finally thought that their eating might be problematic only when one of them underwent open heart surgery and the other man required bariatric surgery.
And across the board, there are quite a few clinicians, psychological clinicians, but also medical doctors who will not diagnose binge eating, in adolescent boys. For a variety of reasons, it's hard to identify. But also there are some clinicians who just believe that boys don't have binge eating disorder, which is, or boys can't have binge eating disorder. It is normal for them to eat a lot and have extra cravings at that age. So we're just not gonna touch it, which is, we got some personal thoughts on that.
Same, but yes. So then there's also this question of just whether men know what treatment even could do. So if there's a general hesitation to engage in psychotherapy, we need to overcome that in the space of disordered eating as much as in any other sort of mental illness realm. And then here I put this cause for hope, which is that in my master's thesis, I found that men, hypothetically, in the abstract, were very supportive of other men receiving therapy for disordered eating. So even if they themselves didn't want to go, hypothetically, they would give the thumbs up to other men who were brave enough to seek treatment.
Okay, so I'm going to touch on these really quickly. If you're going to take away any research findings from today, I really want these to be it. So first off, more recent research has looked at gender roles and masculinity-related variables in relation to eating disorders in men, particularly muscle dysmorphia symptoms. And very interestingly, have found a potential bidirectional relationship between muscle dysmorphia symptoms and endorsement of masculine norms, including emotional control. And I really want to highlight this because when we think about emotional control as measured as it typically is by the CMNI, this is items like I never share my feelings, right? Men who endorse higher levels of emotional control are also less likely to engage in help-seeking behaviors and engage in social support-seeking behaviors. So men who are most at risk for developing the muscle dysmorphia symptoms are also then at risk for lower social support and lower help-seeking behaviors, really creating this negative feedback cycle that keeps them entrenched without being able to get and access help, whether that look like a formal going to a professional for help or even just talking to a loved one about what they're experiencing. It's really important. The standardized mortality rate does not appear to significantly differ across genders. So while there may be some qualitative differences in the experience of men and women's and boys and girls eating disorders, the same number of men or the same proportion of men with eating disorders are dying, just the same as women and girls with eating disorders. However, as Ross mentioned before, there is growing evidence that despite these disparities in treatment seeking, which is concerning considering that the SMR is not changing, there are minimal differences in treatment outcome between men and women. So when we can get men in the door, they actually do quite just as well as women in terms of eating disorder treatment, which is really fantastic.
And I think might also raise some interesting questions about men who are not coming to treatment. Like it might be something like the men who come to treatment do well because they are somehow qualitatively different from men who do not come to treatment. And so I think when I consider the grand arc of the research that I would like to do, I'd like to get better at identifying men with eating disorders so that eventually we can test existing interventions for men with eating disorders, but this expanded field of men with eating disorders so that we can see if those treatments work as well for them. And then if not, we can work on some of the more gender-tailored interventions that I think Callie poses as a future research direction. So here, I think in the interest of time, again, I'm going to say screening and assessment is not great. I'm going to focus my dissertation on developing a brief screening tool specifically for disordered eating in men. So in a couple of years, I'd love to be able to say that we have more psychometrically sound screening tools for disordered eating in men. And then we can probably just move on, Callie.
Sounds good.
Okay, so regarding treatment, yes, we've already said outcomes are largely similar across genders. Unsurprisingly, CBT has the most evidence to support its effectiveness for eating disorder treatment. And I have this question about how good are the outcomes, though, even if it is the most evidence-based? Well, we know that across the board for men and women, under 50% of patients with anorexia and bulimia will actually reach remission, and around 50% of adults with binge eating disorder will reach remission. So there's plenty of room for improvement. There are some general principles that won't surprise any of you about how we can treat eating disorder specifically in men. So yes, it is so very important that we normalize the condition, that we collaborate with men so that they feel like active partners in this therapeutic work. We need to pay attention to their muscularity-oriented symptoms, not just their thinness-oriented symptoms. This is sort of reminiscent of the presidential initiative for this year, but we need to focus on men's strengths when we're treating them. We need to understand how masculinity fits in, and we need to figure out how there's a connection between adherence to masculine norms and also to eating disorder thoughts and behaviors, which is in the next bullet point there. And then, yes, we're also thinking about how to provide practical skills so that men feel like they're taking away some tangible, usable skills from the treatment. And then finally, we just need to pay attention to what we think about men with eating disorders, about who those men are, about how they got there, and about what we can do with them.
Fantastic, Ross. I'm going to jump through these quickly as well. If you want to do research in this field, or if you have questions about what research doesn't exist yet, this is it. So firstly, men are often excluded from eating disorder research. My supervisor, we've got a couple of grants going right now where we see both boys and girls in terms of treating what treatments are most effective for bulimia and for binge eating disorder in teens. When our grant first went through, to the NIH, they suggested that we exclude boys entirely because it's likely that we won't be able to conduct any gender differences in the sample, and we won't get enough boys in the sample, which we pushed back. They dropped that point, so we do treat boys and girls and gender diverse individuals. And I'm delighted to say that about 40% of our treatment sample right now in our current study is boys. So I think it's really important that these stereotypes they go up to really the top of the top. And it's really important that we're making sure as clinicians who do focus on working with boys and men that we're educating other people about this. There are no RCTs for body dysmorphic disorder, muscle dysmorphia, which is also a huge issue. I forgot my clinical comps. There we are. Oh, I've shoved that in a drawer. Was on working with a man with muscle dysmorphia for 9 months. And we're actually working right now on publishing that as a case study, because the more case studies that get published, right now there's only like 3, the more likelihood that we will get funding eventually for an RCT, which would be fantastic. We talked about screening and assessment tools. They are initially developed in samples of women and girls, and they have yet to be validated, or they don't hold up very well in boys and men. There are no studies examining prevention programs exclusively in boys and men. It focuses on the prevention of risk factors, and hint, hint, these risk factors have been identified through samples of girls and women, but not eating disorders themselves. So greater research really needs to be done on how these prevention programs work for boys and men. Neurobiological studies of eating disorders in men are non-existent. It is quite frankly very hard, I think, to get those samples in for that kind of research in particular. And also when you consider about funding as well, if that's impacting our treatment research, it's probably also impacting the grants that neurobiological scientists are getting as well. And then finally, there is almost no research on systemic efforts to reduce barriers to eating disorder treatment in men. So we've talked a lot about what stops men from being able to access treatment. And that's about as far as the literature goes. So we really need to be at the point now, with how the research has exploded over the last decade, working on, okay, how can we actually reduce this gap? How can we get more men and boys in the door? What works? Very quickly, we need increased research assessing the prevalence of muscularity-oriented body image and disordered eating presentation. I mentioned that prevalence estimates are terrible right now because for a number of reasons that we've talked about today. Are men with food insecurity at increased risk of developing eating disorders? Right now, we don't know. Is there increased research, or we need increased research on prevention programs and systemic interventions designed to decrease those disparities in treatment, access, and utilization? And then finally, increased research on the efficacy of gender-specific adaptations to treatment. Lots of people encourage, manuals encourage, they put like 1 page within the manual on, maybe you should talk about some of these masculinity-related variables with men, but there's been no research studying how effective that is for men with eating disorders. Anecdotally, I found it to be very helpful in my case study, but there is no research out there on it, so. All right, we did it, Ross. So that is all the information we have for you today. Thank you. If you have any questions that you were saving to the end because you really didn't want to interrupt us, now is the time.
Just to say, I want to say thank you. That was a great presentation. I think it's really important what you guys are doing. And I'm going to have to jump off and get my next meeting. But thank you.
Agreed.
Thank you
This
so
was
much.
great, y'all. Me too.
Can you bring up the people? Can you get rid of the screen sharing?
Yes, of course I can.
Do you?
Awesome. And then Andrew, I saw that you had your hand raised.
Yeah, so like as a generalist who works with men, like if there were 3 things that I should know when I'm either assessing a new client or working with somebody who discloses some ED related concerns, like what should they be? Or how should I react? Like, I mean, beyond the just acceptance there.
I've got
Hallie,
one, Ross. We can go 1 for 1 if you want.
Sure, sounds good. Okay.
Which is if they brush it off, which is about 9 out of 10 times, stick with it for a little bit. If it gets brushed off and comes back up again, maybe bring it back up again. have that extra listening ear for maybe they're trying to say this is normal, but maybe it's not. And maybe it is distressing for them, and how can I do a better job of maybe identifying that? And part of that is just sticking with it, I think.
And I think, Andrew, I mean, you mentioned this acceptance piece. I assume that that's sort of along the lines of normalization, not seeming totally stunned when they bring it up.
Yeah.
So I think that's important. And also, I think it's just imperative that we recognize again that disordered eating can occur in men who look any type of way. And so we need to be expecting it even in sort of unexpected places. That
Dr.
might only be
Levan.
two, though.
Oh, I just wanted to congratulate you two. As I was listening, I was thinking, gosh, this could have been one of our master classes. It was so well done. So we have involved ECPs in doing these lectures, probably not students yet. I don't think we have done students. Holly or Andrew?
We haven't, but I think this presentation is one of the best I've seen in a long time. It was spectacular, I have to say, not just and I think it's worth presenting an APA, put together a proposal to present it at APA at least.
Yeah. But I'm
But-
thinking we're probably limited by the being an APA CE provider. My interpretation is that we need licensed psychologists to be presenting because it is CE for
Yeah, no, I meant at the
Not licensed, but doctoral.
doctoral. Okay.
I meant convention.
Okay. I know
Yeah.
what you were talking about. I was just clarifying what I was talking about. I agree with what you recommended, but I was just testing
Yeah.
the waters. It sounds like having a separate student series is probably the way to go. And but it's really excellent work. You guys do
Yeah.
good work.
Thanks
Thank you so much. And I'm glad I didn't turn off the recording before we got to hear these compliments, but I will turn off the recording now.